Always give a chance. This is a case of 80 years old child with total retinal detachment due to gore injury. After performing cataract surgery, he was advised to perform retinal surgery elsewhere. He was referred to me and surgery was done. First plan of vitrectomy, I'm just trying to release the iris, but I couldn't due to strong adhesion. Once I got in posteriorly, the retina was folded upon itself like a closed flower. I have to go by manual, using manual technique, using 2 forceps. I'm trying to open the retina very cautiously to not injure any viable retinal tissue. After opening the retina a little bit, injecting perfluorocarbon to stabilize the retina. Then I am trying to remove any membranes and adherent vitreous to the retina to release the edges of the retina, one part at a time, very cautiously and very slowly, gently removing the adherent membranes and hyaloids to open the retina. This could not be done except by manually. Going from the temporal side of the retina to the nasal side of the retina, superior and inferior, and after successful complete release and opening the retina, now I am trying to flatten the retina by flattening the star fold areas. A macular fold was found, limited ILM peeling was done to the macular area. Using the Thanos scraper to flatten the retina more. Then, by manually holding the retina with one hand and using the scissor to perform radial cuts to be able to flatten the peripheral retina as much as possible, no diathermy was used. Multiple radial cuts was done to be able to successfully flatten the retina. Then after successful flattening the retina, perfluorosilicon oil exchange is performed and lasering the retina at 360 degrees. After 2 months, the retina was totally flat under silicone oil. Silicone was removed and an extra row of laser was done. And then, as the patient was traveling, I wanted to implant an IOL. We couldn't implant an iris glow because we couldn't have a proper iris, and pupilloplasty was unsuccessful as the iris was strongly adherent to the wound area. There was no 3-piece IOL with the biometry of the patient, so I had to use a normal 1-piece IOL with a Prolene 4-point fixation, a technique that I use in this situation. Passing the Prolene through the IOL both sides, making my marks. Then I'm going with the Prolene from both sides using the needle, and the IOL is then fixated. Using the 4-point fixation is much better than 2-point fixation as it gives you a better stabilized IOL. Here we can see I'm fixating the IOL, cauterizing the Prolene, and the IOL is well centered, and actually the patient had a very good visual acuity of 0.3, and this is the surprise that we were all happy about.